Good morning, this is Dr. Samarth. I will be conducting a lecture on resective osseous surgery. First, we will begin with an introduction. Why is resective osseous surgery needed? Damage resulting from periodontal disease manifests in variable destruction of tooth supporting bone. Bone deformities are not uniform. Bone loss has been classified either as horizontal or vertical. Bone loss is combination of horizontal and vertical loss. Horizontal bone loss results in relative thickening of marginal alveolar bone. As you can see here, thickening of marginal alveolar bone. Thickening of marginal alveolar bone and development of vertical defects leave the alveolar bone with countless combination of bony shapes. Method of osseous recontouring is followed to alter these physiologic changes and provide a more physiologic bone pattern. Terminology which we will be using: ideal osseous form, a bone consistently more cornal on interproximal surfaces than on facial and lingual surfaces. Similar interdental height with gradual curved slopes between interdental peaks. Ideal architecture, positive architecture. Interdental bone is more cornal than radicular bone. Physiologic bone contour is regular, rounded, and smooth in shape. Flat architecture, reduction of interdental bone to same height as radicular bone. Negative architecture. Interdental bone is apical to radicular bone. Here you can see positive architecture, flat architecture, and negative architecture. Definitive osseous reshaping implies that further osseous reshaping will not improve overall clinical result. Compromised osseous reshaping indicates a bone pattern that cannot be improved without significant osseous removal that would be detrimental to overall result. Interdental septum, the bony separation between adjacent teeth in a dental arch. Interradicular septum, a thin bony divider within the tooth socket that separates the root to a multi-rooted teeth. Here you can see in this diagram a mandible with teeth removed to demonstrate components of alveolar bone. A demonstrates outer alveolar plate, B inner alveolar plate, C cribriform plate lining the socket wall, D interdental septum, and E interradicular septum. Definition: what is resective osseous surgery? It is a procedure by which changes in the alveolar bone can be accomplished to rid out of deformities induced by periodontal disease process or other related factors. These are procedures to modify bone support altered by periodontal disease, either by reshaping the alveolar process to achieve physiologic form without the removal of alveolar supporting bone, or by removal of some alveolar bone, thus changing the position of crestal bone relative to the tooth root. Rational: why is it needed? Elimination of periodontal pocket depth and improving the tissue contour to provide a more easily maintainable environment. Subsequent management of overlying gingival soft tissues to provide a more easily maintainable environment. Reshaping of marginal alveolar bone to resemble that of alveolar process undamaged by periodontal disease. Achieving hard tissue physiologic contour, a physiologic bone form that resembles anticipated gingival architecture. Interdental bone is cornal to facial and lingual bone. Interdental bone is conical. Interdental bone is pointed anteriorly but flatter at molars. Bone morphology follows CEJ, that is cemento-enamel junction. Objectives: pocket reduction, reducing persistent inflammation, because if bone defect is not corrected, inflammation will persist, regaining bone physiological contours, improving interproximal access for hygiene, surgical access for subgingival calculus, improve flap adaptation over bone. Indication Indication for osteoplasty according to World Workshop in Periodontics are buccal or lingual bony ledges, tora, etc. Intrabony defects associated with tilted molars, shallow buccal or lingual intrabony defects, flat interproximal areas, elimination of deep interproximal defects to achieve physiological contour, incipient furcation involvements, and for improvement of alveolar contours for flap adaptation. Ostectomy has been indicated for elimination of interdental craters, intrabony pockets not amenable to reattachment and regenerative procedures, horizontal alveolar bone loss with irregular marginal bone height, and moderate and advanced furcation involvement. Other indications include generalized periodontitis with pronounced and irregular bone loss on several teeth, tissue architecture that prevents adequate plaque control, hemisections and resections of individual molar roots, abutment teeth for plant prosthetic replacement, persistent probing depth of greater than 4 mm after phase 1 with horizontal bone loss. Contraindication in every case where closed or regenerative therapy can provide sufficient results and where aesthetics is important. Areas of insufficient remaining attachment to where ostectomy might unfavorably alter the prognosis of adjacent teeth. Anatomic limitations, for example, prominent external oblique ridge or zygomatic arch, effective alternative treatment. Patient cooperation is other factor for contraindication. A patient who fails to cooperate during cause-related phase of therapy, typical recall schedule of periodontal patient involves professional consultation for supportive periodontal therapy once every 3 to 6 months. Patient who cannot maintain satisfactory oral hygiene over such a period should normally be considered unsuited for periodontal surgery. Cardiovascular disease. These include arterial hypertension, does not normally preclude to periodontal surgery. Patient's medical history should be checked for previous untoward reaction to local anesthetics. Local anesthetics free or low in adrenaline may be used, and an aspirating syringe should be adopted to safeguard against intravascular injection. Angina pectoris does not normally preclude periodontal surgery. Drug use and number of episodes of angina may indicate severity of the disease. Pre-medication and sedatives and use of local anesthetics low in adrenaline are often recommended. Then myocardial infarction. Patient should be subjected to periodontal surgery within 6 months following hospitalization. Thereafter, only in cooperation with physician response for the patient. Cardiovascular disease, arterial hypertension. Anticoagulant treatment. Consultant with patient's physician to determine whether modification of anticoagulant therapy is indicated. Patient on higher level of anticoagulation, adjustment of anticoagulant drug therapy usually need to be initiated 2 to 3 days prior to dental appointment. Anticoagulation may be safely resumed immediately after periodontal surgical procedure since several days are needed for full anticoagulation to return. Aspirin and other NSAIDs should not be used for post-operative pain control. Furthermore, tetracyclines are contraindicated in patients on anticoagulation drugs due to interference with prothrombin formation. Rheumatic endocarditis, congenital heart lesions, heart vascular implants. These involve risk of transmission of bacteria to heart tissues and heart implants during the transient bacteremia that follows manipulation of infected periodontal pockets. According to recommendation of American Heart Association, 2 grams of amoxicillin administered 1 hour before the treatment is an adequate regimen. In case of patient allergic to penicillin, clindamycin 600 milligram is recommended as an alternative. Organ transplant. In organ transplant, medications are used to prevent transplant rejection. Prophylactic antibiotics are recommended in transplant patients taking immunosuppressive drugs. And patient's physician should be consulted before any periodontal therapy is performed. In addition, antiseptic mouth rinse 0.2% chlorhexidine should precede the surgical treatment. Blood disorders, if medical history includes blood disorders, exact nature of these should be ascertained. Patients suffering from acute leukemias, granulocytosis, and lymphogranulomatosis must not be subjected to periodontal surgery. Anemia in mild and compensated forms do not preclude surgical treatment. More severe and less compensated forms may entail lowered resistance to infection and increased propensity for bleeding. Hormonal disorders, diabetes mellitus, entails lower resistance to infection, propensity for delayed wound healing, and predisposition for arteriosclerosis. Well-compensated patients may be subjected to periodontal surgery provided precautions are taken not to disturb dietary and insulin routines. Corticosteroid therapy, then neurologic disorders, multiple sclerosis and Parkinson patient may in severe cases make ambulatory periodontal surgery impossible. Smoking, although smoking negatively affects wound healing, it may not be considered a contraindication for surgical periodontal treatment. Clinicians should, however, be aware, however, that less resolution of probing depth and smaller improvement in clinical attachment may be observed in smokers than in non-smokers. Advantages: produces immediate and predictable reduction in probing depth, improves access for daily oral hygiene and periodic maintenance, preserves gingival width via apically positioned flaps, allows complete removal of granulomatous tissue, allows visualization and access of definitive debridement of radicular surfaces, permits recontouring of bone anomalies, establishment of physiological gingival and osseous architecture, establishment of favorable prosthetic environment, allows appropriate access for root resection and hemisection when necessary, facilitates recontouring of restorative overhangs, and permits restorative crown lengthening where indicated, reduction in pathogenic bacterial colony. Disadvantages: it causes recession, reduces tooth bone support, removes bone that may be needed if implants are desired. Exposed roots could be at a higher risk for caries in patients with poor oral hygiene, more access for brushing, but more challenge for patient to maintain, post-operative pain, edema, and tooth loss. Now we will come to pattern of bone destruction. Here we can see that plaque-induced gingival inflammation causes extension of inflammation along collagen fiber bundles following the course of blood vessel, interproximally through collagen fiber bundles and blood vessel perforating interdental septum at center or through the side of crest, facially and lingually through outer periosteal surface which penetrate marrow spaces through vessel channels in outer cortex. This leads to destruction of transseptal fibers, replacement of marrow with leukocytic and fluid exudate, new blood vessels and proliferating fibroblasts, resorption within marrow spaces by osteoclast and mononuclear phagocytes, thinning of bony trabeculae, enlargement of marrow spaces. This leads to bone loss. What is radius of action? Page and Schroeder, on basis of Verhoek's measurement made on human autopsy specimen, postulated range of effectiveness of about 1.5 to 2.5 millimeter, within which bacterial plaque can induce loss of bone. Beyond 2.5 millimeter, there is no effect. Interproximal angular defects can appear only in spaces that are wider than 2.5 millimeter. Rate of bone loss: Low et al. In a study in Sri Lankan laborers with no oral hygiene and no dental care found that rate of bone loss on an average was of about 0.2 millimeter a year for facial surfaces and about 0.3 mm for proximal surfaces. Now, classification of osseous surgery. Osseous surgery can be additive or subtractive. Additive is restoration of alveolar bone to its original level. Subtractive is resection or removal of bone, which could be definitive, which establishes a positive or normal parabolic osseous form, or compromised, which indicates an osseous topography requiring extensive osseous removal that would be detrimental to long-term prognosis of tooth. Additive osseous surgery causes regeneration of lost bone, re-establishment of periodontal ligament, gingival fibers, junctional epithelium at a more coronal level. Subtractive osseous surgery is alternative to additive method, should be used when additive procedures are not feasible. Instruments which are used are Oxenbean chisel number 1 and 2, Oxenbean chisel number 3, Skulger bone file 910, Sugarman bone file 3S4S straight, Whittle star chisel, tray scaler by Coblets, Rhodes chisel 3536, Rongers. Rotary instruments which we use are burst surgical length round number 468, burst surgical length and cutting, burst surgical length finishing, round flame shape. Here you can see diagram of oxygen bean number 1 and 2, A and B. C is bone chisel, oxygen number 3, and D is Skulger curved file number 910. Here this is Sugarman bone file 3S4S, Vidal start chisel, Friedman Ronger, 90-degree blue menthol Ronger. A and B are rotating fine-grained diamond stones used for debridement of intrabony defects, and C and D are round ones used for bone recontouring. Osseous surgery could be osteoplasty and ostectomy. Osteoplasty is reshaping of alveolar bone without removal of tooth supporting bone. Ostectomy is removal of tooth supporting bone. Osteoplasty, this term was introduced by Friedman in 1955. It is a plastic procedure by which non-supporting bone is reshaped to achieve physiologic gingival and osseous contour for following purpose: pocket elimination, tori reduction, intrabony defects adjacent to edentulous ridge, incipient furcation involvement, reduction of thick heavy ledges or exostosis, shallow osseous craters, blunted interdental crater. Osteoplasty is a technique analogous to gingivoplasty, purpose of which is to create a physiologic form of alveolar bone without removing any supporting bone. Removal of non-supporting bone may sometimes also be required to gain access for intrabony root surface debridement, leveling of interproximal craters, and elimination of bony walls of circumferential osseous defects are often referred to as osteoplasty, since usually no resection of supporting bone is required. Osteoplasty, here you can see in this diagram, leveling of interproximal bone crater through removal of palatal bone wall. For aesthetic reason, buccal bone wall is maintained to support the height of the soft tissue. Ostectomy. In ostectomy, supporting bone, that is bone directly involved in attachment of tooth, is removed to reshape deformities caused by periodontitis in marginal and interdental bone. As a general rule, however, care must be exercised when supporting bone is to be removed. After exposing the alveolar bone by elevation of flap, buccal and or lingual crater walls are reduced to base of osseous defect using bone chisel and bone rongers. A round burr or diamond stone under continuous saline irrigation can also be used. If bone resection has been carried out in interdental area, the buccal and lingual palatal bone margins may subsequently have to be recontoured to compensate for discrepancies in bone height resulting from interdental bone resection. It is considered important to remove the small peaks of bone which often remains in areas of these line of the line angles. Here you can see osteotomy procedure. This is positive architecture of bone. In gingival margin and crest of alveolar bone are parallel to cemento-enamel junction of teeth. Gingiva and alveolar bone occupy a more apical position over radicular surface of teeth and more coronal position interdentally. Architectural pattern on facial and lingual palatal surface is scallop. On proximal surface of teeth, bone assumes an important architectural pattern that again parallels the cemento-enamel junction and is influenced by buccal labial to lingual palatal dimension of teeth. Final relationship among the tooth, gingiva and bone is created by the context of anterior and posterior teeth within the arch. Proximal bone generally assumes a pyramidal shape for incisor teeth and a convex or parabolic shape for premolar and molar teeth. Negative architecture if interdental bone is more apical to radicular bone. Flat architecture, reduction of interdental bone to same height as radicular bone. Selection of treatment technique. One wall defect present with either one proximal wall, one linguopalatal or buccolabial wall, generally not amenable for regenerative therapeutic procedure. Resective procedure create a more physiologic architecture, providing a more stable and predictable long-term result. Two wall defect bordered by two proximal wall, a buccal labial and proximal wall, a buccal labial and lingual palatal wall, constitutes approximately 1/3 of all intrabony defect and 2/3 of all mandibular defect. Two wall defect bordered by two proximal wall, buccal labial and proximal wall or buccal labial and lingual palatal wall constitutes approximately 1/3 of all intrabony defect and 2/3 of all mandibular defect. Osseous crater management dictated by vertical depth of crater, thickness of crater walls, location in dental arch, tooth type, root trunk length. Resective osseous surgery is applied in shallow and moderate interdental crater. Deep craters are more suited to regenerative procedures. Osseous resection applied to two-walled intravony defects result in attachment loss from at proximal line angles and facial and lingual aspect of affected teeth without affecting the base of the pocket. When the technique is properly applied to appropriate patients, the mean reduction in attachment circumferentially around the tooth has been determined to be 0.6 mm at 6 probing sites. Three-wall defects constitutes 3 osseous wall and tooth surface constitute 4 wall, may be localized to one proximal or mid-radicular surface or may be circumferential, involving 2 or more root surface. Resective procedure is totally contraindicated in 3-wall defect. Factor influencing performance of osseous resection. Performance of osseous surgery to eliminate significant osseous defect requires a knowledge of an appreciation for not only normal soft and hard tissue anatomy, but what the morphology of osseous architecture will be after elimination of bony defect. An optimal result also requires an optimal understanding of differences between flap design for access and debridement and flap design required for intimate adaptation of flap to osseous platform. Factors influencing performance of osseous resection, root form and root trunk, tooth inclination, location and type of bony defect, alveolar margin alterations, percussion involvement, vertical defect. Influence of root form and root trunk. Root trunk length is an important anatomic factor in diagnosing and treatment plan of post multi-rooted teeth. Root trunk length is measured from distance from cemento-enamel junction to furcation. Oxenbean classified molar trunks into maxillary and mandibular categories with different dimensions for teeth and two arches. Here, arch Classification and dimension. For maxillary, short root trunk is having dimension of 3 millimeter, medium of 4 millimeter, and long root trunk of 5 millimeter. Mandibular arch. Here, short root trunk is classified as 2 millimeter, medium as 3 millimeter, and long root trunk as 4 millimeter. Procedure: soft tissue palpation, radiographic examination. Radiographic examination provide information about interproximal bone loss, presence of angular bone loss. It does not identify presence of periodontitis, not accurately document extent of bony defect or the number of bony wall remains. It can indicate presence of intrabony pocket when there is angular bone loss, irregular bone loss, pocket of irregular depth in adjacent areas of same tooth or adjacent teeth are found. Probing, it reveals presence of pocket depth greater than that of normal gingival sulcus, location of base of pocket relative to mucogingival junction and attachment level on adjacent teeth, number of bony walls, presence of percussion defect. Then transgingival probing under local anesthesia provides a detailed information regarding the extent and configuration of intrabony component of pocket or percussion defect. Consists of probing through the gingiva until the resistance from bone is met. Probe is wound along tissue tooth interface to feel the bony topography. Probe may pass horizontally through the tissue to provide three-dimensional information regarding bony contours, allows healthcare provider to identify the shape and dimension of underlying osseous defect clinically without reflecting the flap. It helps to corroborate and expand on information provided by radiographic examination and is useful in planning surgical treatment of periodontal defect. Procedure: internal bevel and trabecular incisions are given using scalpel and BP blade. Vertical releasing incision at each of the end points of the reverse incision. Elevation of full thickness flap beyond the mucogingival line. Removal of marginal collar of tissue, including pocket epithelium and granulation tissue with curettes. Thorough scaling and root planing of exposed root surface. Recontouring of alveolar bone in order to achieve physiologic bone contour. Buccal and lingual flaps are repositioned to level of newly recontoured alveolar bone crest and secured in this position. Here is the diagram. Osseous resection technique. After establishment of adequate flap thickness, initial thinning incision, buccal and palatal lingual flaps are reflected for surgical access. Removal of tissue tags. The root surfaces are thoroughly scaled and root planed using a clear view of marginal bone and bony defects. Resective procedure comprises of vertical grooving, radicular blending, flattening of interproximal bone, gradualizing marginal bone. Vertical grooving and radicular blending are osteoplastic procedure. Flattening of interproximal bone and gradualizing marginal bone are ostectomy procedure. We will discuss about all these procedures and other techniques for resective osseous surgery in next lecture. Thank you.